Carmen comes from the Southwestern Adoption Center, and Alyssa Barucci, who works at our Women's Adoption Center here, wrote this like really beautiful paragraph about you, talking about how you just really kind of embody this and teach this in a way that has primarily focused on abortion providers, but I think we're really, really lucky to expand this to our care of obstetrical patients, gynecological patients, and women who are seeking to have their pregnancies.
So I work at Southwestern Women's Options in Albuquerque, New Mexico, and we provide abortion care in all trimesters. And so the majority of our patients do present in their first trimester. But we also care for women seeking later abortions. And sometimes we see them for 2, 3, or even 4-day abortions. And women have later abortions for lots of different reasons, including financial or other issues related to access, late diagnosis of pregnancy, late diagnosis of a fetal anomaly, etc. But we also see a lot more women who have had significant sexual trauma. And so, there was this quote from the Global Doctors for Choice that I thought was really interesting, because it's one of the few recognitions of the relationship between sexual trauma and pregnancy, actually, that was based on any sort of science or reality. But they were condemning gestational age limits, I think specifically in Latin America, the few countries where abortion is legal in cases of rape. And they said women and girls who've been raped often repress the experience because it's too hurtful to remember. They may overlook or misinterpret early signs of pregnancy and may delay seeking medical help. These are frequently observed reactions to rape and can lead to late diagnosis of pregnancy, end quote. And we often see younger patients who've been too ashamed to tell their parents about the rape, and so they hid the pregnancy for that reason and delayed the abortion that they had already chosen in their mind as soon as they suspected that they might have been pregnant. But girls and women who have remote sexual trauma may maintain that coping mechanism of diminished communication, is kind of what I call it, for lack of a better word, from the body to the brain, and they are at a higher risk of late diagnosis of pregnancy in general. All of this is not to say that those of you who are doing maybe early abortion care or doing anything other than abortion care are not going to see lots of folks with sexual trauma, but rather the intense experience of those patients who are having an induction abortion and the sometimes profound relationships that we share with them over the course of several days has provided me with an opportunity to develop a more advanced understanding of how to make this experience, and by extension, the patient care in general, less bad. So that's kind of my perspective and where I'm coming from. So this might seem kind of obvious, given the nature of our symposium, but my talk particularly can be emotionally challenging to listen to and to give, frankly. So when I started my intern year, so brand new doctor, and I had, one of my first patients who just needed a pap smear, just, regular well woman exam. I found myself feeling very inadequate. There were moments during that interaction in which the patient was in pain and was afraid as a consequence of my action. We're doing a computer update right now. That's okay. And I remember kind of walking out of that room, not really understanding what was going on, but feeling, the only way I could describe the way that I felt was that I felt like I had raped someone. And I began what was a very long search to guide me, to find someone or something to guide me into a better way of taking care of patients. Because I knew a little bit that there was something going on prior to the experience that she and I had had in that room. But I couldn't find anything. I didn't find anything on PubMed or on UpToDate or on Dynamed, and on the Google. And I started looking at my attendings and looking for them to model for me what I should be doing differently. And what I found more than anything else was that they were eliciting similar reactions from patients and that they were less affected by it. So there's been so much published on trauma within a counseling framework, but not very much from a medical framework, and particularly when we're talking about the more vulnerable healthcare experiences. So, and then, it's been pretty recent that the A study came out, and we were just kind of joking about this over lunch, like, it took a study of 17,000 people to realize that when terrible things happen to you during your childhood, that it fucks you up when you're an adult. But unfortunately, that's how it works nowadays. For something to be true, we must study it. We must gather data and evidence. And then, this morning we were in a space where there were people who were understanding that it's not enough just to have an ACE study and to understand that adverse childhood experiences cause poor health outcomes, but then to take that a step further and say, how can we change our interactions with patients to try to mitigate the effects of trauma? So essentially, the model that I feel works really well for me and in our setting is that through a very intentional change in the doctor-patient dynamic, and by extension, I would say nurse-patient, social worker-patient, medical assistant-patient dynamic, and with the use of a few very specific techniques, we arrive at 4 basic elements, which are to recognize that sexual trauma is very common, and we know that, but 2 weeks ago, I was at a huge conference. There were maybe 500 people in the audience, and I asked people how common they thought childhood sexual abuse was. If you ask women in this country, how many women have had childhood sexual abuse, and people thought it was somewhere around 1 in 10 was the most popular answer. Sexual assault or attempted sexual assault in adolescence and adulthood, similar statistics, and we know that that's just not the case. And then remind ourselves that her fear is legitimate, and I think that this is a really big challenge, and we'll talk a little bit more about this over the next hour or so. And that one of the principal factors in changing this dynamic is that she has not, up until this moment, had very much control over her body, perhaps, and then we're gonna give her some control over her body. So I don't have to tell you that these are probably very conservative estimates based on adult self-reported recollections of their childhood. Most child sexual abuse is perpetrated by a trusted adult. And that is an important nuance, that this was somebody that you were actually supposed to be able to trust. Survivors of childhood sexual abuse are likely to experience rape as a teen or adult. And notice I don't say more likely, but rather they are likely to experience rape. And teen survivors of rape are likely to be raped again as they move into adulthood. So again, I'm going to speak about this today from my experience as an abortion provider, but some of you, many of you, maybe provide other types of healthcare, including primary care, and I don't want you to get stuck in thinking that this is the only setting in which trauma-informed care will improve patient outcomes. We've been hearing about primary care for HIV-positive patients, domestic violence work, etc. But abortion care is a setting that offers a lot of cues that can trigger physical or emotional memories of past abuse, and that has made it an important venue for this work. But these triggers are not exclusive to abortion care or to gynecological exams or procedures or to invasive procedures that are available in any healthcare setting, as well as in our personal lives. And so I think that these concepts can be used in other settings very successfully, and I'm hoping that we'll have some time to brainstorm about how, in the different settings that you all find yourselves, what might be applications that are useful and possible. And boys and men also experience sexual violence, and trans men and women are even more vulnerable, and everything that we talk about today I feel is very applicable to their experiences. And many women who are experiencing intimate partner violence may also be experiencing sexual assault from their partner. And even when that isn't the case, I feel like we can usually talk about this approach to patient care and replace the word sexual trauma with intimate partner violence, and it would be largely applicable. But there are so many restrictions, and because of the heavy stigma surrounding abortion, many women keep their abortion secret even from their partners or their closest family members. And then the presence of the anti-abortion extremists on the way into the clinic, which I don't think that you have here at this hospital because of the way that it is structured, but we certainly do have that at my clinic. And they act in a very bullying manner, and they use fear and intimidation tactics. And although abortion is so common, most women have no idea of how it actually happens. So we're removing, taking away knowledge and therefore control. And then she has to expose her genitals to one or more strangers, and she expects that it will be excruciatingly painful. And though with education and experience, we get better at noticing these red flags, things that before you even meet the patient, you see her medical history or you hear about her from whoever has done her intake or her counsel. And these things will increase our suspicion for trauma once we have more education and experience. But I've been really badly burned when I thought that I could rely on screaming and breeze through an interaction without using a trauma-informed lens. And while it's very important to recognize that there are risk factors for the purposes of prevention and treatment, we have to also remember that childhood sexual abuse, for example, is ubiquitous across socioeconomic categories. So this morning there were a couple of speakers that gave us what I thought were pretty terrific definitions of what trauma means. And a couple of people, when I told them I was coming to a trauma symposium, they thought it was like, like ER, like, femur fractures and stuff like that. And I think it's more similar than we sometimes allow ourselves to recognize. But I think of trauma as the damaging effect that we experience when an event or series of events causes a stress that overwhelms our ability to cope. So when we talk about trauma in the ER, we mean the damaging effect of being cut or shot or struck by an object that overwhelms the abilities of our flesh, our bones, our internal organs to remain whole. And psychological trauma is when this happens on an emotional level. And our ability to heal is determined by several factors. What state are we in before this happens? Are we healthy, well-nourished? Are we updated on all of our immunizations? Are we rushed into the arms of a capable healer who will tend to each broken part with compassion and all the right tools of the trade? Or are we left in a ditch by the side of the road for our wounds to heal and jagged scars? And will we be respected and loved after surviving the trauma, despite, and maybe even because of the way that it changes us? We often choose not to call non-consensual penetration rape because we will not or cannot perceive ourselves as a victim or the perpetrator as a perpetrator. What about a traumatic experience that was not perpetrated by an individual with the intent of dominating and violating another person? Can a medical trauma have the same effect? We all embrace that possibility. Can the socialization of girls and women in a misogynistic culture have that effect? I prefer to simply acknowledge that girls and women are exposed to a huge variety of actions and messages that are intended to and very effective in taking control and wholeness away. So the simple fact of being born a phenotypic female places us somewhere on this spectrum. And privilege, as we see in other areas of health, and by that I mean the usual stuff like being white and able-bodied and hetero and male if you have that, financially stable, educated, that those things give us some measure of protection from trauma as they do from so many other harms. And also the privilege of having a loving and functional family and a supportive healing response to a traumatic event or events gives survivors a larger armament of coping mechanisms. So just as we ask ourselves what constitutes trauma, we might also ask ourselves what constitutes a traumatized person. And so really it is the collective effect of the traumatic event or events, the person who experienced it, and the subsequent help and emotional support that they were able to access that determines the presence of PTSD or other reactive entities. Just as we remember facts and details that help us to grow and learn and function, so do we also have visceral memories that provide us with emotional context in our interactions. And what we call instincts, really, which are the things that protect us from so much harm. We hear the word trigger used frequently in this context when talking about trauma, and it describes any information that provokes this visceral memory. And so these triggers right here, and I've categorized them into emotional and physical triggers, but there are so many more. Triggers act as messages to the brain that say, you're in danger. And they are important, we need them. When we feel something that we felt during abuse or an assault, we can begin to re-experience other aspects of that moment as well. And as more and more of those sensations join in, the trauma can really be recreated. So what might start out with shame as we walk through the anti-abortion bullies outside the clinic may lead to muscle tension and tachycardia, which then trigger fear, which means that now a sensation that normally would be slightly uncomfortable is perceived as painful. And if we're not paying attention to the potential triggers and noticing the responses to those triggers, full-blown flashbacks can occur, and it becomes very hard to regain control. I want to take a small step back from kind of the more narrow subject of sexual trauma for a moment to look at some of the big picture issues involved in the caring professions. And some of this was touched on earlier today in a really profound and eloquent way. And some of this we were talking about over lunch. It gave me a good opportunity to remember what I was supposed to be talking about. And I was kind of anticipating that we were going to have some police officers in the room, but that didn't pan out, shockingly.
Invited.
And they were invited. They're still invited. So who's a healthcare provider, clinical person? Okay. Teachers, because sometimes you can identify as more than one. I also identify as a teacher. Anyone? No? Yes, okay. Social workers? Or, ish? Therapy people? Okay, sweet. So one of the things that we were talking about, and it started off because we were talking about sociopathy, and I was being an optimist and saying that, in fact, there are not that many sociopaths out there. And that I think, and I am going to take a step outside of my usual personality to be very optimistic and say that the people that go into these professions probably mostly do it for the same reason. Do you guys agree? Like, people want to help other people, and they think that they'll be good at it. But then so many things happen. We don't get the training and the skills that we need. And we don't get the education that helps us remember the history of our professions and maybe our race and maybe our gender. And then we find ourselves very surprised when this person, this patient or student or community member or client, they don't just inherently trust us.
Can I add something?
Yeah.
You're not taught to think about your own trauma.
Absolutely.
Stuff.
Absolutely.
Process that.
Two people are bringing their past and they're into the present. Absolutely. And so then we will step into an exam room or a classroom or a client's home or any other setting, and we approach this person and we really feel like we're ready to save them, you know? I've had those moments. I'm like, but I am a nice white doctor and I am here to help you. And when that person is afraid of us, and that might manifest as fear, but it also might manifest as anger, or it might manifest as dissociation, or any other number of things that are not satisfying to us, or not what we were expecting, we don't get the reward of having that person be grateful and just trust that we're there to help them. Because they don't actually have any reason to trust us. And so what can happen very easily when we aren't getting that emotional reward is that we go and we grasp out for that other thing that's available to us. And the really easy one to do when you're in one of these professions is to have some power and some control over that person. And so if you're a police officer and that's happening in your interaction with a community member, someone can end up dead, or their life can be ruined with an arrest. And when that happens in healthcare, someone can end up dead, or lives can be ruined. We can re-victimize someone in that moment, but we can also push patients even further away from feeling entitled and safe enough to access healthcare services. And that can result in lives lost or ruined. And my husband's a teacher, and we've been talking about this a lot. And when that happens in the classroom, students fail or drop out, and perhaps don't ever return to an educational setting. It means that school to prison pipelines can be formed very easily. I've been spending a lot of time speaking particularly with law enforcement about this, and I think we're kind of getting closer to being on the same page, not necessarily in any kind of productive way, but so there are some folks that I've been talking with about this, and I think that they really identify with that. But particularly when I talk to them about, these are the challenges that I see for myself. So if I am a healthcare provider and I feel like sometimes I want my patients to trust me and know that I'm there to help them. And yet there are these things that are in the way, and then I sometimes just get really bossy pants with them, and that I think makes it really easier to hear. I spent some time talking about these emotional triggers because I think that they're obviously very ubiquitous in the setting of abortion care, but certainly labor and delivery, and I think we could also say so in healthcare settings in general. But also because I think that we can gently usher them out. So I'm just going to pause for a moment and talk about Chuck E. Cheese. Has anybody ever been to Chuck E. Cheese?
Yes.
Yeah. On a scale of 1 to 10, how terrible of an experience did you find it to be? Maybe you like it, I'm not trying to judge, but so I have an 8-year-old and an almost 7-year-old, and one of the many terrible things about being a parent that they don't tell you about is that you sometimes have to go to these birthday parties. And we had to go to one, it was a Chuck E. Cheese, and we really had to go. It was like a social obligation. And so we go to Chuck E. Cheese, and there's really loud music, there's a lot of flashing lights, there is a gigantic robotic talking rat, I'm not even kidding. They don't serve alcohol there, and there's screaming children everywhere. So my husband and I are like clinging to each other, white knuckled, like cold sweat, and just trying to breathe. We can stay for 45 minutes and then we can leave. It's gonna be fine. And we see this little girl, and she's playing, she's not even 3 probably, and she's just playing, she's having a great time, and she's high on soda pop and cake, and she's wearing this really ridiculous frilly princess dress, and she's doing these somersaults on the floor, and her mother runs up to her and grabs her and pulls her dress down and says, "Stop that right now, everyone can see your privates," because her underwear was showing. And so my husband just kind of leaned into me and he said, "The shaming of the poo." And that has become a code word that we use for whenever we notice that happening, where like the having of the body part is shameful. And so I was inspired to look up the origins of the words poontang. And I don't know about you guys, but in my line of work, I have learned so many words. Did you know that you can call it a cookie or a pocketbook? And I don't know, there's a million words, but these ones I think are very interesting. And so apparently it originates from the French word putain, which means whore. And so if every woman is a whore based on her ownership of a vagina, then shaming becomes part of the female existence. And this is what we're up against in the best of circumstances. Survivors of sexual trauma, especially when the abuse occurred in childhood, often suffer from shame. Child abusers tell their victims that the abuse is normal, but eventually she realizes that it isn't. And then he tells her that it's her own fault. The abuser then teaches her that she deserves to be abused. She feels ashamed of the fact that she has this body that provokes sexual desires in others, of her genitals made as they are for sex, and she perceives them as being abnormal, ugly, and dirty. She's then ashamed of being pregnant because that's evidence of having had sex, and then she must take off her clothes, put herself in a highly vulnerable position, and undergo a potentially painful exam or procedure. And that shame can remind her of the shame that she felt when she was raped as a child, and then she isn't in the present anymore, and it's not just a speculum that she feels inside of her. And for those of you who are working clinically, you know that when you're signing out your patients, that this is a word that we use, right? So-and-so in room 2 is very difficult. And so remembering that many times the patients who are the most difficult are simply those who have had sexual trauma. She isn't hard, she's had a hard life. And that's actually a thing that I find myself saying to my own self over and over again, sometimes out loud, sometimes inside of my head. Because sometimes she's really difficult. So that's an important one to remind ourselves of what's going on with her and in that room. The body of a survivor remembers those traumatic experiences, and sometimes you really do have to say that out loud, not just to yourself, but sometimes with her in order to start to change that dynamic. She knows that other providers have found her to be a hard patient. And so if you change the way you see her, and then maybe change the way she sees herself in that dynamic. In our clinic, the patients are usually with a counselor talking for, I would say on average, 45 minutes before I meet them. And a common question that I'm asked when I first meet her is, will it hurt? And I know that has already been covered extensively in her counseling session. So she's asking me something bigger. She is asking me, will it hurt her? Or she's telling me that it will hurt her. And so I'll say something along the lines of, for a lot of us, the hardest part is when the speculum is placed, because many of us have had experiences in which we were not in control of our bodies. And this is the moment where she stops fidgeting and she looks me right in the eyes, because she realizes that she's not the only one, and she realizes that I'm talking to her. And I really liked what Dr. Kimberg was talking about this morning about not requiring disclosure to provide people with the care that they need. And that's something that I feel really strongly about. There are some studies, and people talk a lot about whether or not we should be screening for intimate partner violence, for history of sexual trauma. And in my setting, I sometimes have a very brief moment with her, and I sometimes don't have good referrals and good resources to offer her if she came from 3 or 4 states away. And so I think that this is a really important thing. I am allowing that experience to be in this room without her having to disclose. So then I continue on and I say that this is different. This is not something that someone is doing to you, but rather something that you are doing for yourself to take care of yourself. And I want to explain what's going on with triggers for her in a way that makes sense. And so I'll say something along the lines of, our bodies are very intelligent and they want to protect us, and that's the purpose of fear, right? Fear tells us, you're in danger. And there are things that we do when we're afraid, or like the mild version of afraid, which is anxious or nervous, but it's the same thing. We tense our muscles and we hold our breath. And people, when you say that to them, they know that. Oh yeah, we all do that, and they kind of do this thing with their body. So when we do the opposite of that, when we make our muscles soft and heavy, and when we take slow, deep breaths, we can send messages to our brain that say, you're safe, it's cool. And then we can change the way that we feel sensations in our bodies. So when we tense the muscles of the vagina around the speculum, even though the speculum doesn't have any sharp or pokey parts, it can hurt because those muscles are really strong. And so it's my job to notice if those muscles are tensed and not place the speculum if that's the case. So if the speculum hurts, I'm not doing it right. And my job is to remind you to make those muscles soft and heavy before I place the speculum. And if you notice that I'm reminding you over and over again, it's not a criticism, because when it's our turn on the table, we all need to be reminded. And that's very important too. So notice how I explained pretty simply, in a way that it seems that most people understand really, really well, that number one, she is not abnormal, but rather something abnormal has happened to her like many others. She is not a hard patient, but rather she has had, the hard time that she has had is part of a normal reaction to her past experiences. And so she might start to relate this not just to pelvic exams, but to maybe dental exams and procedures, to sex, because that all can come into play. So understanding that her reaction is normal, right? And that understanding why we react this way, then we can begin to control that reaction and send messages to our brains that change that feedback loop. And then this right here is not a violation, but it's rather something that is under her control in a healing environment and where touch is compassionate and just. So at doctor's appointments, and I am a doctor, but I also feel this way, that I'm supposed to be quiet and still and obedient. I don't know if any of you have a different experience. I think that there are some people who don't feel that way, but they're in the minority. And that as a patient, you should be uncomplaining and ask few or no questions. And we all feel really anxious when we're not in control, and that can be like a fun kind of anxiety, like when you're on a roller coaster, or it can be a terrifying anxiety, like when you're on a plane with really bad turbulence. But for survivors of trauma, lack of control was fundamental in the traumatic event or events, and it becomes a very powerful trigger. And so giving that back can be very healing and calming. So to every single patient, not just patients who I have flagged as being at high risk, but to every single patient, I say something along the lines of, you are in control of how this goes. Even when we're all set up, we'll just check in and make sure that you're ready before we start. Even though this process might not take very long, if at any point you feel like a break would help you, you say break, hands come off. And if once we get started something is uncomfortable or hurts or is making you feel afraid, please tell us, because a lot of times we can make it feel better really easily, and we really want to try to do that. And certainly there are going to be some people who you will spend more time on this with, and some where you might do the basics. But I think that those three elements are really, really important. We start when you're ready to start, we take a break when you want to break, and we want you to communicate your feelings, and then we will respond, right? So, and then I really am constantly challenging myself to take anything that would normally be a command and turn it into a question, and sometimes it sounds really absurd. And the first thing that I do is I knock on the door and then I wait before I open the door. And that, I think, is really powerful. I remember, being at the hospital and you've got, 20 patients to round on by 9:30 a.m. and you're in a super big hurry and you kind of knock on your way in the door and the patient's like, oh God, I didn't have my pants on. And there is something really powerful about knocking and then waiting, because although she is probably not going to say anything, you are allowing for her to say, don't come in. You are letting her know that that is actually her space, and you're asking permission before entering. And for example, the nuanced difference between asking, what questions do you have, versus, do you have any questions? It feels really different to be asked those two things. In fact, patients are sometimes like, I'm sorry, I don't have any questions. As opposed to feeling kind of guilty about having anything that you actually want to talk about. And for example, before doing a heart and lung exam with a stethoscope, I ask permission, is it okay if I listen to your heart and lungs? Nobody's ever been asked that question before, and they can't believe it, but we're touching them in this part of their body. For example, when I'm done meeting them and I'm going to step out of the room, I say, if it's okay, if you wouldn't mind taking off pants, underpants, and shoes, rather than undress from the waist down. And so I really urge you, and it seems really absurd, but just to go through, like, what are your usual lines? And we've all got, like, the 10 things that we say 20 times a day. How can you turn that into a question? Things that I think are really important, before I lift up that drape sheet and expose her perineum, I am always going to ask her if she's ready, even if somebody else has done something first, because sometimes the nurses will do the pericervical block before I go into the room. And so she already has a speculum placed. She doesn't need it to be open to the free air. And when I'm done with procedures, particularly later procedures, I will ask her, is it okay if I clean you off with a cool wet wipe, rather than just going for it? Those things seem to really make a big difference. And then, in my practice, and probably in all of your practices as well, looking for every opportunity to eliminate surprises. So, for example, touching the ankles or the lower legs before touching the inner thighs or the perineum. Avoiding the sensitive anterior introitus. So all of the sensitive parts are really in one area, and it is very easy to avoid them if we spend a little bit of effort on that, and I'll talk a little bit more about that later. Avoiding instrument noises. So the clicking of the tenaculum or the ring forceps, the sounds of the speculum rattling around, instruments touching each other on your thread. When people are already highly activated, they're so much more sensitive to sound, to any visual stimulation, any sort of touch. Little things like on our instrument trays, we have a blue kind of cloth paper thing underneath our instruments, and sometimes I'll notice that it's just kind of tickling her toes a little bit. And so I've made it part of my routine to just make sure that it's not going to touch up against her toes. She doesn't need that extra sensation right now. Avoiding touching the lateral vaginal walls with gauze, something that people just go in there and they wipe around in the vagina, and it feels really uncomfortable, and that's something that we can actually avoid with a little bit of effort and skill. So the other thing is we asked our patients, and again, those of you who aren't doing abortion care or gynecological care, we're asking people to tell us when they're not comfortable in this setting and other settings. But then we have to actually listen when they tell us, and that can be the hard part. You're like, darn it, I meant it as a rhetorical, you're free to tell me when things aren't comfortable. And so taking that as an opportunity to reinforce that communication rather than an unfortunate side effect of wanting people to communicate. So sometimes people will, the speculum is in place, for example, and they'll say, ow, and I'll say, well, where, where is it uncomfortable? Oh, it's the, the thing and the thing. And I make this just the smallest of homeopathic speculum adjustments. And I say, well, there, does that feel better? And 100% of the time she says, yeah, that's so much better. It's like, at the beginning of the procedure, there is a need to just confirm that that whole thing that we talked about being able to communicate and you listening to me, I just need to check and see if that's actually going to happen. And so you have to really back it up. And sometimes you're backing it up with big things, but a lot of times you're backing it up with, I hear you, I respond, is that better? Yes, it is, check. Women often apologize for communicating pain or asking questions, and I just try to not engage in them. And I say things like, do not be sorry, you don't have to be sorry, I really want to know if something's bothering you. And I just keep saying that over and over and over again. So for example, when I'm doing a paracervical block, and for those of you that aren't in this field that's putting lidocaine or numbing medicine into and around the cervix, if she feels discomfort at some point, I might say, did you feel that? That's a really sensitive spot, it sounds like. So I'm going to put some more numbing medicine right there, and that way you'll have a nice numb cervix. Let me know if you feel it again, and we can get it in all the right places, right? So here, all of a sudden, she is participating in her procedure, becoming successful. Rather than, that's going to go away in just a second, which is also true, but it's not building on that relationship of mutual good abortion creation or whatever else thing that you're doing. And then, do any of you guys use Versed or midazolam in your practice regularly? So I just want to very briefly touch on the Versed issue, which not everybody agrees with me about this, but I feel that there are some patients that do much worse with Versed because it can really strip away some important coping mechanisms. And so if you're like a super high functioning person that feels safe, you expect to have safe, good things happen to you, then stripping away some of your coping mechanisms can be awesome. It can be like, now I feel so relaxed. But if that is not you, then stripping away some of your important coping mechanisms means that you're 2 years old. And that doesn't work very well because 2-year-olds don't get abortions. There's a reason that they don't get abortions. And then she is so far enough away from the present that we don't have the ability to help her have any control of what's going on. And so I use it very carefully in patients who seem very activated with their trauma in my setting. And sometimes I will actually have to step away and wait for that medication to wear off and then come back and try again. And it usually doesn't take that long, which is great, but that's available because usually it's not an emergency. So we talked a little bit about the speculum placement thing, and I really did want to go back to that because I have medical students, residents, and fellows that rotate through my clinic. And one thing that I've noticed is that oftentimes I'll have someone who is, say, an advanced point in their fellowship, or maybe they have even practiced out in the community for several years, and I make it a first step to teach them how to place a speculum, because that is a really important skill, and we oftentimes don't learn how to do it very well. In fact, I learned how to place a speculum after residency by one of the nurses that worked at the clinic forever, and her dad. So this is how we're taught to place a speculum. You like stick it in that way, and then you like crank it around, and so all of the sensitive stuff is like right here. And it doesn't usually look like that when you're doing the little cranky thing. So the proper speculum placement, in my opinion, it involves keeping it straight up and down, placing the posterior blade of the speculum at the posterior introitus, using lots of pressure downward, 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 and avoiding the anterior introitus. Notice that I don't say insertion of the speculum, but rather placement. And I always say placement even when I'm not talking with patients. I don't accidentally say I'm going to insert the speculum or the speculum is going in now. But then it's hard because then you can't say taking it out either. But I figured out that I can say I am done with the speculum now. We are done with the speculum now. So what other things? So other issues with speculum placement is you don't have to open that sucker up all the way at the very beginning. And people, that is how we were taught. You place it, and then you just like crank it up, and you want to have like, you know, a 12 by 12 view of the cervix. And sometimes we do need to have really good visualization, and I end up at that place, but we don't need to start off there, right? If you're starting off by just finding the cervix and numbing the cervix, all you need is that much cervix, and then you can get started, and then very slowly open as you go until you have the visualization that you need. And there are some really, I think we need to have, those of us who are in clinical settings, we need to have like 3-hour courses on speculum placement and cervix finding, and I would love to be part of that, but we're not going to go into it right now. But there are lots of ways to minimize the discomfort involved in this. So I really want to open up for lots of conversation and questions. This is heavy and really just skimming the surface. But I first want to give a shout out to some of my teachers. So Marissa was a 16-year-old patient who came in for a 9-week abortion, and she was like just cute as a button, had these like bright twinkly eyes, and she would just look you right in your eyes. And when the counselor was giving me the chart so I could go meet her, she said, "She's great, she's gonna do great, no issues." And I walked in, I sat down, and I asked her, did she have any questions? And she said, "Nope, I think I got everything all, squared away with the counselor, let's go, I'm really hungry." And I was like, phew, finally an easy one, And so then we were very busy that day, and so the nurse was keeping ahead of me. So she would go in, she'd place the speculum, she'd do the paracervical block, and then I would go in, and I call it my ninja in the night move, right? Where so like just go in, bam, bam. She's like, "Oh, I feel a little crampy," and I'm like, "Okay, we're all done now." And she's like, "Wait a second, that only took 60 seconds, and it makes me look really good. So I like to do that, and also saves a lot of time. So I walk into the room thinking that she's already going to have the speculum placed, numb cervix, ready to go. And there's the nurse who's like really, really good at placing speculums, going like this, and the patient's going, "Ow, ow, ow." So I was like, okay. So then she puts the speculum down and covers her up, and I'm going to switch seats with her. And Marissa says, "Sex always really hurts too. Do you think it has anything to do with the fact that I was raped by my uncle when I was 7 before I went to foster care?" And there was this, collective moment, and I said, "Yeah, you might be right about that. There might be some connection there." And so then she told us her story, and so she, like many survivors of childhood sexual abuse, was convinced that there was something terribly wrong with her genitals, right? And that everything hurt because there was something wrong with her. She had some sort of disease thing. And so I said, I think that you're right, and I don't think that there's anything wrong with your vagina, but I will let you know when I have a chance to really examine you. And we started off by doing some perineal muscle training. So basically what I say is something, I'll say, I'm just gonna touch on the very outside with a finger, and you're gonna let me know if something is uncomfortable or if it hurts. And I'm literally just touching at the very bottom of the introitus. And oh, that doesn't hurt, okay. And then I get to a place where I'm really where the strong muscles are. And then we do some muscle training, right? So I say, I want you to squeeze my finger as hard as you can, and she does, and when she does, I push down. Just a little bit of pressure. And that doesn't feel great, right? That feels a little sensitive. And I said, well, you're very strong, and now go ahead and make those muscles soft and heavy. And as she does that, I release some pressure. And then we do that a few times, and she learns how to squeeze muscles and soften muscles. And she gets the feedback that squeezing is more uncomfortable and softening is not. And then we were able to place the speculum really easily. She was amazed because it did not hurt her at all. She had a very quick, easy, pain-free abortion. And afterwards was amazed. And I said, you know, you will also be able to have sex that is not painful, but you need to be in a place with people that you feel safe with. You need to be patient. Your partner needs to be patient. And, you know, and then I give her this book that I give people, which is called Sex for Survivors, which is really awesome, by the way, if people want to buy a case of used ones on Amazon like I do and give them out to teenagers. And so she really taught me about the importance of universal precautions, right? So you think that you know who they are, but they are all of us. And so it is really only when we're able to apply the trauma-informed care concepts to every patient that we're going to give everybody the care that they deserve. And Destiny was someone who I took care of pretty early in my career. She was a 13-year-old who was under the care of her grandmother and was complaining of back pain, and so her grandma took her to the doctor and they did an x-ray, and there was like a little upside down skeleton inside of her. And so they traveled to New Mexico for her to have her 3rd trimester abortion. It was at that time that she disclosed to her grandmother that her stepbrother had raped her, and she hadn't told anyone. And she was a kid, you know, she was 13, but she was a child. And she was really scared, and she had a lot of trauma, and it was really hard to take care of her. And then on the day in which we were inducing her, so we do a couple of days of cervical preparation for inducing labor, we got to this point where we couldn't figure out if she was having a hard time coping or if she was in labor, and really needed to assess her cervix, and she was having none of it. And we all who've worked on labor and delivery or in triage know about when you're doing that cervical exam or trying to, and the patient is just getting further and further up until they're like on the pillow. And so Destiny and I had a little strategy session, and we figured out something that really worked, and that was that I was going to just place one finger right there. And she was going to move her body towards my fingers at her pace until we got there. And it took like 20 or 30 minutes, but we got there, and she was fine. We were talking, you know, we talk a little bit, and we talk about basketball a little bit, and then she'd be like, okay, I'm going to move a little bit. I'm like, okay, I'm not moving. And I had to get myself in a really comfortable position that I could sustain for a really long time. But she really taught me that, sorry, the wiggling around has begun, that when you get the concepts, that when you really get what it's about, you can do it in any setting, you know, on a boat with a goat, in a house with a mouse, and that has served me very well. And then there is Yvette and many, many other like her who taught me that sometimes even when you pull out all of your best moves, it's going to feel terrible. And she's going to cry, and she's going to moan, and she's going to say, please, 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 and it's just going to feel like the worst thing, and that you're not going to survive, and she's not going to survive, and somehow at the end of the thing, you're about to walk out the door, and she says, thank you so much, I thought it was going to be so much worse. And you're like, are you fucking kidding me? How could it be any worse than that? And so remembering and keeping some reserve there for when it's just terrible. And even when you're so busy and you don't have 5 minutes to cry and let it all out and talk to somebody about it, because you've got somebody in the stirrups right next door and you need to go. And that even though in that moment you feel like, you know what, I need to hang up my hat and get a job at Starbucks as a barista because I am really bad at this and I should probably just step aside. But that's how it's going to be sometimes, and she just will inspire you to keep trying more. And that's it for my big spiel, but I really would love to hear what you guys have to say about the matter. Things that work, things that you'd like to try, things that you'd like advice on, and if anybody wants to chat with me more, that's my email address.